Marlene Toffrivijnen. I'm a nurse by background and now I'm a professor of learning disability and palliative care at Kingston University in London. In this presentation, I will give you some background about learning disability and some statistics related to end of life. I'll go through some of the unique challenges faced by this population. I'll remind you of the Daffodil standards, and then I'll explain how you can use these Daffodil standards to address the challenges and ensure that people with a learning disability receive end-of-life care that is in accordance with their needs and wishes. And I'll also show you at the very end of this presentation a new toolkit for supporting end-of-life care planning with people with a learning disability. So why should you focus on people with learning disabilities? Well, they form a significant minority group. Learning disabilities are thought to affect around 2% of the population. So if access is equal, that should be 1 in 50 of your patients, although you're unlikely to be aware of all of those. Estimates are quite difficult because it's thought that about 79% of those are a hidden population that is unknown to health and social care services. The LEADER programme run by NHS England reviews the deaths of people with a learning disability in England, and in the 2022 report, based on around 3,500 deaths, it was found that the median age of death of people with a learning disability was 63, and that's more than 20 years earlier than the general population. And 42% of those deaths were found to be avoidable. And that's almost twice as many as in the general population. And the top 3 causes of avoidable mortality for people with a learning disability were related to cardiovascular conditions, respiratory conditions, that's excluding COVID, and cancer. And people with a learning disability were also significantly more likely to die in hospital. There are no equivalent mortality review programmes in Wales, Northern Ireland or Scotland, although the Scottish Learning Disability Observatory published a systematic review of deaths of people with a learning disability in Scotland in 2017, and findings there were similar to those in England. There are many challenges, but here are some of the key challenges to be aware of. So this population has extreme multimobility at a young age, and the average number of other mobilities is 11. So here are some questions for you to think about. Are you aware of the specific comorbidities in this population that increase the risk of premature mortality, and have you planned for this? So, for example, people with Down syndrome who are in their 50s are at a very high risk of developing dementia. Those kind of things are useful to be aware of. And multimobility is complicating. It may well obscure the signs and symptoms of life-limiting conditions, and it complicates the management of the illness, including symptom control at the palliative stage. It also means that this population has an increased risk of developing frailty at an earlier age than the general population. Some of the other issues, it can be quite difficult to spot when somebody is approaching the end of life. That's more difficult and it's happening at a younger age. So one thing you can do, are you monitoring the frequency of hospital admissions in this population and seeing whether the person actually has returned to baseline on discharge? Does your annual health check spot evidence of developing frailty or dementia at a young age? Do you have any reasonable adjustments that people need recorded using the national flag? And the reasonable adjustment that you need can be very wide-ranging and actually highly individual. So, for example, many people are likely to need more time, they need a quiet space, they might need accessible information, and that is something you might expect. But someone might also really need to have their specific comforter with them, for example. That's worth noting down, or only eat one kind of food, or need a particular carer to be with them. So record those things. Communication and shared decision-making can be challenging. So do you find opportunities at the annual health check or at other times to talk about people's wishes, their fears, their anxieties for the future? And carers can really help you with communication. So do you involve them as partners in care? So here you have an overview of the Daffodil standards. You're probably familiar with those. I'll come back to them and I'll give you some ideas for using these Daffodil standards to support people with a learning disability and their carers. But before you do that, it's important that you gather baseline information about your practice to see how you are doing in relation to the care and support of people with a learning disability. And that doesn't have to be a difficult or an extended audit. So, for example, you could just reflect on the last 5 patients with learning disabilities who died at your practice, or whatever is a relevant sample size for your particular practice. And you could then specifically consider with these patients, these cases, if reasonable adjustments were made and recorded, if communication needs were recorded and flagged. So, for example, have you included how the person communicated their pain, their symptoms, their distress? Was it known and recorded how, where, and by who the care was provided? Did the patient live with family? Did they live alone with support? Did they live in a residential care home, for example? These are quite significant questions because that really affects how the patient is supported and who provides that care. And have you identified who the main carers are and who speaks for the patient? And as I said earlier, really involve those people as partners in your care. Care plans and DNA CPR, was that discussed with patient, with family, with carers? Were they made on an individual basis? Were they reviewed regularly? How about the access to your service, face-to-face, by telephone? Was that appropriate for the patient? Was it what they needed? Continuity of care, that is often very important with this population. Was there a named physician? Did the person see the same physician each time? And was there a named contact for the practice, an individual guidance on how to contact the practice for this patient? These are just some ideas about things you could reflect on. And then you might present those findings back at the practice clinical or MDT meeting. You could discuss, confirm, document your plan to build any ideas and improvements to your practice. So, for example, ensuring that these questions are considered routinely for people with learning disabilities on the palliative care or the relevant practice register. That was quite a simple audit. You could also do a wider audit to see generally what the uptake is in your practice of annual health checks and health action plans, and check that the actions on those are completed, and also to see if advanced care planning is discussed and how that is discussed. You could also do an audit for risk factors or think about risk factors for approaching the end of life. And those, for example, are, as I mentioned earlier, an increased frequency of hospital admission, and especially note those if there is a failure with return to baseline. Malignancy diagnosis, people with Down syndrome who are over 50, they may have a dementia diagnosis. Look at evidence of developing frailty, but do remember to use a learning disability frailty indicator, and note that the clinical frailty scale should not be used for people with a learning disability. Look for increasing frequency of falls and epilepsy, for example, with high risk on CDAP assessment. And with regard to training, you could see, for example, what proportion of your staff have completed the Oliver McGowan training. And with all that in mind, let's look at some examples of SMART outcomes for the Daffodil standards. We've listed some here on this slide, but just some ideas about how you could actually, using the SMART goals, look at each of these standards, looking at an increase of staff who develop the training, an increase of people who die who've been on the palliative care register. You may look at an increase in people on the palliative care register where the caregiver has been identified and the notes were made recording of the nature of care provision. So all these are just some examples of things that you might do. And here you can see a few more. Look at the proportion of patients with a learning disability who have their annual health checks completed. That should really be quite high, at least 90%. But also then look for an increase in discussions in advanced care planning and annual health check. taking into consideration the multimorbidity that this population is at risk of. So again, just have a look at these examples and see if there's anything there you can do practically to meet the Daffodil standards. And so before we finish, let me tell you about this toolkit of resources and approaches to end-of-life care planning with people with a learning disability, which was launched in 2024. And this toolkit is freely available online. You can download quite a few of those resources for free at www.victoriaandstewart.com, or just scan the QR code. That was a toolkit that my team developed with the involvement of almost 200 people, including 36 people with learning disabilities, families, support workers, managers, health and social care workers, researchers, policymakers. It was the result of a 2-year NIHR-funded study. And all these people together tested existing resources for end-of-life care planning, and they included in the toolkit the ones that really worked well, but then co-designed a whole range of new resources and guidance. And this will be particularly helpful to facilitate meaningful discussions and shared decision making. And they can be given to both formal and informal carers, because you yourself may not have the time to really go through this with your patients in detail, but also give it to health and social care professionals. It also includes guidance on how to involve people who don't have capacity or who lack verbal communication skills. And I also want to draw your attention to a 3-year study that is running until 2027, which will give us important new insights into how we can ensure that all people with a learning disability get optimal and timely support at the end of life. So keep an eye on that website and on social media too. And here is a final message from a group of people with a learning disability who helped to produce the toolkit. What they worry about most is they don't know what words to use when they talk about death and dying.
Oh, right, okay.
So,
well, it's just the same words that you would use with anybody else.
Yeah.
Obviously, it's individual. So if you talk with me about death and dying, that's not a problem. I can talk about that. Yeah, I might get upset, but that doesn't matter because you can deal with that.
Don't talk down to us. Talk to us as human beings. Respect us. We respect you, and we are adults, not kids.
if we train the staff and we say what you've got to do is create a safe space, how can they do that? What makes you feel safe in a space?
A space that the person you're supporting feels calming, that they know, that they're used to, and just allow them to speak openly and not just listen with so the staff can not just listen with their ears, but they listen with their eyes as well, because that's really important. You've got to recognise when people are getting upset or whatever. So just if you're supporting someone really well, you should know what their safe space is, what their good day is, what makes them tick, what calms them down.
Time is limited. Talk about it now.
Yeah, very good.
Very good. Very good, Leon. I like that. Time is limited.
Talk about it now.
Now. Yeah. You can do it.
That's a good one.
Yeah.
That's a good one.
You can do it.
You can do it.
You can do it.
Yes.
Yes.
Woo!
Woo, yeah.
Thank you very much for watching this, and here are some of the resources and links to things that might be helpful in supporting this very vulnerable and important population. Thank you.